So this started for me with a couple of problems that I don't have solutions for. And here's a couple examples. And particularly parasymphyseal fractures have been difficult to treat. There's different options for it with anterior column screws, infix, xfix, like Dr. Rout alluded to, or ORAF, but particularly focusing on these parasymphyseal fractures. So this was a case, just to start it off, of something that went badly. But this is a 47-year-old female that got ejected from a car. She had multiple injuries, as you can see, some other injuries that got taken care of first, her head injury, her open fractures and everything. But she ended up with an LC1. I think we would all agree that this is an unstable injury. Here's a CT scan going through it. And so this transverse superior ramus fracture. These are just some images, and this is how I fixed it. I thought that this was good enough. You can see the X-Fix pin again for the reduction, but the X-Fix pin in the top two images showing how much distraction, and this is after I fixed it, taking the X-Fix pins and stressing the pelvis and moving it with internal and external rotation. And so she was touched on weight bearing for other injuries, but had a head injury, so she didn't really follow the directions with that. It also affected her other injuries as well, but this is her follow-up imaging. And so this was just a representative case of a problem that I've run into and trying to find a solution for it. So I'm gonna show some techniques where the CurvaFix has helped with that. So this is a 71-year-old male, and this is kind of that high energy geriatric trauma that all of us see. He was MVC, got T-boned on the left side. He had other injuries and this LC1 pelvic ring injury. This was his trauma bay x-ray. This was his x-ray after when we got our formal x-rays, and again, showing his CT scan here. He got his other injuries taken care of, and then he was having significant pelvic pain, couldn't roll over in bed, couldn't get out of bed. So talked to him about fixation and took him to the OR for fixation of his pelvis. So these are some techniques for the anterior pelvic ring and some of the stuff that I've learned using this implant, but it's essentially the same starting site as the anterior column screw, the classic anterior column screw. I use the 4.5 millimeter drill bit to start with the 2.0 wire, just like Dr. Rout alluded to, and then you end up using this bent tip wire, which again is a described technique, but I've started going out of the pectineal eminence or symphyseal bone anteriorly, and then making a curve anteriorly and going bicortical there to help get better fixation in there, but also it almost acts as a buttress then, so that as they roll over in bed, the implant blocks the internal rotation deformity for it. So a couple other tips. The exchange tube, the way this works is you put this guide wire down and you have to mallet the wire out to get bicortical, and then you exchange that wire for a different wire to put the implant in. To get that past the fracture, you have to, I found you just twisting it helps a lot. And then if you want to go bicortical, you need to, I ream out the anterior portion with at least the 6 millimeter reamer to engage, to get the threads to engage better, because that's very good bone anteriorly there. And so this would, so this is that curve kind of in the front coming out the bone anteriorly to help prevent the problem that we had on the first patient. So I did this bilaterally on him, and here's his 2-week x-rays. And just like a lot of us have seen, these patients, they don't have pain afterwards, which is kind of incredible. You talk to these people after you fix them and they say, I never had any pelvic pain. Once I got fixed, I never had any pelvic pain. And so his tibia hurt him, his femur hurt him, but he never had any pelvic pain. So this is 2 weeks, this was 3 months. Again, no pelvic pain at all. This is another one that was a little bit of a unique situation. This is a geriatric patient, 88-year-old female, fell in her garden. She presented a week later to clinic, and she has a history of a pelvic fracture and a malunion from 17 years before. So this was a unique situation where she already had a deformity, so a straight screw probably wouldn't have worked as well. again, getting the same starting site, you can use the wire and it can kind of help assist your reduction once you get it in. That's what the top right image shows. And then getting the exchange tube past the fracture helped in this one. And then the exchange tube, you can actually take the wire that you put the implant in and put that wire in at the same time as the bent tip wire, pull the bent tip wire, and then use the CurvaFix implant. And so this was the example of hers. I fixed the other side with it as well for her. She had the parasymphyseal fracture on that side, but she also had a prior malunion and a deformity. So a couple other tips that I've learned using this implant, for the dense bone, whether you're going across the SI joint for a posterior injury or coming out anteriorly to get bicortical. This was a younger patient, younger high energy patient that I used it on. And as I was malleting in the bent tip wire, the wire started to bend. And so it bent a little bit in the pathway, as you can see, but it also started to bend outside the patient because the bone was so good anteriorly at his pubic symphysis. So what I did is I took the 4.5 drill, put it down to strengthen the wire, and then put the T-handle chuck on the back of the 4.5 drill and malleted it through that. And then I was able to get the ball tip out the front. And then ream out the front again with his good bone. And these are the images of him fixed. This was an LC2 pattern, so that's how he got fixed.